Ladies and gentlemen, distinguished guests, and esteemed colleagues, I'm Dr. Nigar, your host for this event, and it's my great pleasure to welcome you to our second OncoConnect Global Summit. Today, we have the privilege of hosting a remarkable guest, Dr. Cristian Buono, a distinguished consultant medical oncologist based in Argentina and Dubai. With over 2 decades of experience, Dr. Cristian has made significant contributions to the field of cancer treatment, particularly in the domains of non-small cell lung cancer, epidermal growth factor receptor mutations, and anaplastic lymphoma kinase translocation in the population of interest. He has also led phase 3 research teams focusing on breast and lung cancer, and currently serves as the Principal Investigator for Oncology Research Clinical Trials at the Mar del Plata Medical Research Center in Argentina. Dr. Cristian will be sharing his valuable insights on advanced non-small cell lung cancer, sequencing agents in the epidermal growth factor receptor mutations, anaplastic lymphoma kinase translocation populations at this summit. Welcome, Dr. Cristian.
Thank you very much, Dr. Nigar, for the introduce. Today we are talking about advanced non-small cell lung cancer sequencing agent in the EGFR mutated ALK translocation population. I have no conflict of interest to declare. So we start with a very simple overview. Personalized therapy on actionable molecular markers had completely transformed the prognosis in advanced non-small cell lung cancer. The goal are to prolong survival and to maintain quality of life for as long as possible. At 5 years, still our overall survival rates are between 15 and 20%. In this section, we review the most common digestible diverse mutations. Patients with advanced non-small cell lung cancer should have tumor acidity for the presence of the driver mutation. Mutation in the EGFR tyrosine are observed in 15% and ALK translocation in 4% non-small cell lung cancer adenocarcinoma in the United States. This set of patients is more frequently in human and non-smoker. Driver mutation can be identified by FISH, immunohistochemistry, and NGS panels. In less than 20 years, we increased progression-free survival from 10 months to 21 months and overall survival also. But what about systemic therapy for advanced non-small cell lung cancer with activating mutation in the EGFR receptor? Tumor growth and progression depend upon the activity of cell surface membrane receptor that control intracellular signaling transduction pathway. This cell surface receptor include the EGFR tyrosine kinase. Analysis for the presence or absence of the driver mutation in the EGFR is the standard approach to decide whether or not to use the EGFR tyrosine kinase inhibitors. Mutation in the EGFR receptor tyrosine kinase are observed in 15% of non-small cell lung cancer adenocarcinoma. Unlike activating mutation in the EGFR receptor, amplification of EGFR does not predict improved outcome with EGFR inhibitors. Overexpression is not sufficiently predictive of activity of EGFR tyrosine kinase to be an appropriate surrogate for the presence of an activating receptor mutation. If high EGFR gene copy number was not accompanied with the EGFR mutation, progression-free survival outcomes were worse with gefitinib compared with chemotherapy. So what about the efficacy of single-agent EGFR TYK inhibitors? TYK inhibitors significantly improve outcome in patients with advanced non-small cell lung cancer that contains an activating mutation in the receptor compared to platinum-based chemotherapy. Although first generation and second generation TKI inhibitors have been the standard of care for initial management of EGFR, newer data suggests improved outcome with frontline treatment with the third generation agent osimertinib. We prefer osimertinib as a frontline treatment option based on randomized controlled trials. Although earlier generation EGFR TKI inhibitors remain acceptable options and acceptable alternatives. So we are going to see the first drug here in the frontline setting is osimertinib. We must see here the Flora study, a randomized controlled trial, phase 3. Here we compare 556 patients to gefitinib over erlotinib. The endpoint here show better progression-free survival with osimertinib, 19 months versus 10 months, better response rate, better progression to central nervous system, and better overall survival, 39 months versus 32 months. The toxicity here was the QT prolongation and decrease in left ventricular ejection fraction. Dacomitinib in the frontline setting. Here we must see the Archer study, a randomized phase 3 trial. Dacomitinib were compared to gefitinib, 452 patients. And here we can see better progression-free survival also and overall survival, 34 months versus 27 months. The main toxicity here was diarrhea, pyronychia, dermatitis, and 66% need dose reduction. EGFR TKI inhibitor plus chemotherapy in the frontline setting. Here we have to see the study, the Japanese study, in where 345 patients were compared gefitinib versus gefitinib plus chemotherapy with carboplatin and pemetrexed. The endpoint here show better progression-free survival, 21 months versus 11 months with the doublets, and better overall survival, 52 months versus 40 months with the doublets. We have never seen an overall survival near one year, a median overall survival. The main toxicity here were very well tolerated with no increase above the expected toxicity. Comparison of gefitinib, erlotinib, and afatinib. The choice of first or second generation EGFR TKI inhibitor should be individualized according to patient and provider preference. Available data suggests that erlotinib, gefitinib, and afatinib all have similar efficacy in EGFR mutant lung cancer and are generally well tolerated. Acquired resistance. Almost all patients who initially respond to EGFR TKI inhibitor develop disease progression. The causes of acquired resistance include secondary mutation in the receptor and amplification of MET. This mutation accounts for resistance in approximately 50% of cases of acquired resistance to early generation EGFR TKI inhibitors. The T90 mutation has also been identified in a small percentage patient with activating mutation in the EGFR at presentation. The use of first-line osimertinib may largely address this T90 resistance. For patients who do not have the T90 mutation or those who progress on osimertinib, Combination chemotherapy with or without the addition of immunotherapy is usually the next treatment option when progressive disease develops. The loss of T90 mutation at the time of progression on osimertinib was identified as a resistant mechanism. Chemotherapy with platinum etoposide is recommended for patients with evidence of small cell transformation after standard EGFR TKI inhibitor therapy. Summary and recommendations. EGFR mutation has favorable response to EGFR TKI inhibitors. Tumor tissue acidity for the presence of mutation in the EGFR receptor is mandatory. We recommend monotherapy with an EGFR TKI inhibitor rather than chemotherapy. In randomized trials, this approach significantly prolongs progression-free survival. We suggest osimertinib as the frontline treatment rather than other TKI inhibitors. Early generation TKI inhibitors like gefitinib, erlotinib, or afatinib are appropriate alternative also. Use of an EGFR inhibitor in combination with standard platinum-based chemotherapy regimen is not a standard option yet. Those who progress on a first or second generation EGFR TKI inhibitor and have the T90 mutation, we treat with osimertinib. Chemotherapy and immunotherapy is an indication for those who do not have the T90 mutation or those who progress on osimertinib. Continuing on an EGFR TKI inhibitor beyond progression and during subsequent treatment with chemotherapy is not recommended and is associated with shortened overall survival. What about the anaplastic lymphoma Keynes fusion oncogene positive non-small cell lung cancer? ALK positive non-small cell lung cancer accounts for 3 to 7% of all non-small cell lung cancer diagnoses. Typically, patients are younger, never smoker, who exhibit adenocarcinoma histology. The discovery of ALK chromosomal translocation in non-small cell lung cancer in 2007 was revolutionized the treatment of ALK-positive non-small cell lung cancer. Testing this fusion gene is not in non-small cell lung cancer is very important. ALK-positive tumors are highly sensitive to therapy with ALK-targeted inhibitors. ALK gene translocation may be detected in tumor or plasma specimen. Brain metastases here are more common. What about the next slide? What about the first-line treatment? We must see, we have, in the first-line treatment of ALK-positive translocation patient, we have 3 drugs, alectinib, brigatinib, and lorlatinib. What the evidence says. For alectinib, we have the study ALEX, in which 303 patients were compared to crizotinib. The endpoint here show better progression-free survival, 35 months versus 11 months, better overall survival, and slow progression to central nervous system. The toxicity here was well tolerated with anemia, muscle pain, and increased weight only. The second drug, brigatinib, we have the study ALTA-L1, in which 275 patients were compared to crizotinib, and the endpoint showed better progression-free survival for 24 months versus 11 months, and better intracranial response, 78% versus 26%. The toxicity, the main toxicity here was hypertension, cough, and muscle pains. And the last drug was lorlatinib. We have the study CROWN, called CROWN. We have almost 300 patients. The endpoint here show better progression-free survival and a strong intracranial response compared to crizotinib. The main toxicity here was dyslipidemia and neurocognitive effects. What about the less preferred options? Ceritinib has shown superiority over chemotherapy, but is less preferred than alectinib or brigatinib due to lesser efficacy in cross-trial comparison. Ceritinib is approximately 20 times more potent than crizotinib. We have the ASCENT-4 study in the first line, in which 376 patients were compared to chemotherapy with platinum and pemetrexed. The endpoint here showed better progression-free survival, 70 months versus 8 months. The main toxicity here was diarrhea, nausea, and vomiting. And although crizotinib is more effective than chemotherapy for ALK-positive non-small cell lung cancer, it should only be used if a next-generation ALK inhibitor is not available. The next study in the first line, we have the PROFILE study, in which 343 patients were compared to platinum pemetrexed, and the endpoint here show again better progression-free survival, 11 months versus 7 months, better response rates, but the overall survival was not significant. Crizotinib, as a conclusion, is superior to standard chemotherapy in patients with previously treated advanced non-small cell lung cancer with ALK positive. Treatment after progression of crizotinib. For ALK positive patients who develop resistance to crizotinib or who are unable to tolerate crizotinib, we recommend treatment with one of the second-generation ALK inhibitors, alectinib or brigatinib. Our preference in this setting is for alectinib or brigatinib, given the central nervous system penetration and better systemic efficacy. Alectinib in the study ALLURE, second line after chemo or crizotinib, in 100 patients, were compared to single-agent pemetrexed or docetaxel. The endpoint here show better progression-free survival, 7 months versus 1 month, and less progression to central nervous system again. The other drug, brigatinib, we have a phase 2 study in which 222 patients were compared to high versus low dose of brigatinib. The endpoint here show better progression-free survival with higher doses, 17 months versus 9 months, and better overall survival with higher doses also, 34 months versus 29 months. What about the treatment after progression on second-generation ALK inhibitors? Lorlatinib overcomes most acquired resistant mutation within the alkanes domains. Lorlatinib was also designed to be highly central nervous system penetrant. Because lorlatinib has activity against most of the no-ALK inhibitor resistant mutation, it is our preferred agent in the setting of acquired resistance to alectinib. However, the presence of an acquired alkanes domain resistant mutation is not required to prescribe lorlatinib. Lorlatinib has activity both in patients with and without detected alkanes resistant mutations. The FDA approval for lorlatinib is based on the result of a phase 2 study that includes a subgroup of 198 patients with ALK-positive metastatic non-small cell lung cancer previously treated with one or more ALK inhibitor. The median progression-free survival here was 11 months. What about later line therapy, chemotherapy with or without high immunotherapy? Upon progression on target agent, we now offer the combination of chemotherapy with high immunotherapy based on a subset analysis of EMPOWER trial. In the EMPOWER trial, the addition of atezolizumab to the combination of bevacizumab, carboplatin, and paclitaxel improved progression-free survival and overall survival in non-small cell lung cancer. The progression-free survival benefit was also seen in a subset of 111 patients with EGFR mutation and ALK translocation also. Special consideration regarding treatment, we must talk about brain metastasis. For asymptomatic and symptomatic patient, second or third generation ALK tyrosine kinase inhibitors should be used, as data exist to each of these drugs regarding brain penetration and central nervous system efficacy. Most patients with brain metastasis, either TKI inhibitor naive or crizotinib, will respond to these agents, and surgery and or radiation therapy may be delayed, therapy reducing patient morbidity associated with these local treatments. Here we have the summary and recommendation for these populations. All positive are often found in lung cancer from relatively young, never or light smoker with adenocarcinoma. We recommend initial treatment with an ALK inhibitor rather than chemotherapy. For those with newly diagnosed ALK-positive non-small cell lung cancer, we recommend a second or a third generation ALK inhibitor rather than crizotinib. In choosing between second generation inhibitor, we typically suggest alectinib. Brigatinib and lorlatinib are other acceptable first options. Therapy should be continued until progression or high toxicity. For patients with ALK-positive non-small cell lung cancer and progression on alectinib, we suggest lorlatinib over chemotherapy or other ALK inhibitors. And for last, for ALK-positive patients who develop resistance to or are unable to tolerate crizotinib, we recommend treatment with one of the second generation ALK inhibitor, brigatinib or alectinib. Thank you very much.
Thank you so much, Dr. Cristian, for your exceptional presentation and for sharing your expertise with us on our Global OncoConnect Museum today. I'm sure our audience has greatly benefited from the knowledge you have shared with us today.
Thank you very much. Thank you.
Thank you. And now I would like to present 2 questions from our audience who are medical professionals eager to learn more about the topic. All right, so the first question is, what's the home message about EGFR based on randomized controlled trials?
Oh, nice, very interesting question. In 2 or 3 words, I can say that in this kind of setting of patient, first line, it will be osimertinib, and first generation TKI inhibitor like gefitinib, erlotinib, or afatinib also are good alternative. EGFR inhibitor plus chemotherapy is not a standard yet. Patient who has T90 mutations, the indication is osimertinib without doubt. Continue TKI inhibitor beyond progression is not recommended. This is the principal message I can say about that.
Thank you so much for your brief answer, Dr. Cristian. Now we also have the second question. So the second question is, what is your treatment option when patient progresses on first generation tyrosine kinase, and why?
Yes, very nice question. My treatment option is alectinib or brigatinib, given the central nervous system efficacy and penetration and systemic efficacy also. We remind here the ALLURE trial, in which alectinib was compared with single agent pemetrexed or docetaxel and showed better progression-free survival. And with brigatinib, we have phase 2 trials that compare high doses versus low doses, and high doses show better efficacy and better penetration to central nervous system. So here we have the advantage to delay other treatment to the central nervous system like radiation or surgery.
Dr. Cristian, we truly appreciate your expert answers and for sharing your insights with us today. Your contributions are very valuable to us during this symposium. Thank you so much once again.
Thank you very much. And it's my pleasure to show and to share these letters and these notes about a disease that have a very long burden in the worldwide that it's affected our loved ones, right? Thank you very much for invitation.
Thank you so much once again. And to our esteemed audience, we are also thankful to you for your engaging questions and for being part of this meaningful event today. And this Global OncoConnect Symposium was brought to you by MedSynapse, a global medical platform that promotes collaboration and knowledge exchange among healthcare professionals. We encourage you to join this wonderful community and continue learning together. Once again, thank you all for your active participation and for being part of this impactful event. Thank you and see you soon. Goodbye.